Arthroscopic rotator cuff repair using a modified Mason-Allen suture resulting in a linked anchor construct, presented by Mark H. Getelman and Nels E. Sampatakos from SCOI. Our patient is a 76-year-old healthy male English teacher who presented with persistent activity-limiting right shoulder pain following a ground-level fall 9 months prior to presentation. Despite attempting various non-operative treatment modalities, the pain has continued to interfere with his job, as well as his ability to lift weights and swim. On exam, he has mild limitations in range of motion related to pain, tenderness over the lateral bursa, 4 to 5 strength and pain with supraspinatus testing, and positive provocative impingement tests. Axillary and Gracie radiographs demonstrate a normal glenohumeral joint space and registry with a lateral sloping acromion and subacromial osteophytes. The scapular Y view shows a 2B acromion with an inferior osteophyte at the distal clavicle, which is better appreciated on the Zenka view. Coronal MRI images demonstrate a full-thickness tear of the supraspinatus directly off the anatomic footprint with approximately 1 centimeter of retraction. Extensive tendinopathy of the remaining supra- and infraspinatus tendons are seen, as well as an effusion within the glenohumeral joint and subacromial space. Mild degenerative changes are noted at the glenohumeral condylar surfaces, and moderate changes are seen at the acromioclavicular joint. Sagittal MRI images again demonstrate the supraspinatus tear, measuring approximately 1.8 centimeters. The remaining rotator cuff tendons appear intact, and there is minimal atrophy. Axial images demonstrate a normal-appearing biceps tendon within the bicipital groove and an intact subscapularis tendon. The supraspinatus tear is also visualized with preservation of the posterior cuff. At arthroscopy, we begin with a standard 15-point diagnostic evaluation of the glenohumeral joint. Viewing from the posterior portal, we note the large delaminated tear involving the supraspinatus tendon with minimal retraction and an intact infraspinatus. When viewing from the anterior portal, we were able to better appreciate the full-thickness nature of the tear. We begin by performing an intra-articular debridement of the footprint on the greater tuberosity, as well as a debridement of the frayed and degenerative appearing tendon edge. This is performed from both the posterior and anterior portals and allows for a more thorough debridement than that which can be performed from the subacromial space alone. Here we see the completed tear and tuberosity after the debridement. Viewing the bursal surface from the subacromial space, we identify the full-thickness supraspinatus tear with a posterior L-shaped component immediately anterior of the intact infraspinatus. A subacromial bursectomy and decompression was then carried out, beginning with debridement of the posterior bursal curtain with a motorized shaver. Using an electrocautery instrument from the lateral portal, soft tissue is debrided from the undersurface of the acromion. Anteriorly and anterolaterally, the CA ligament is gently recessed away from the acromial edge, allowing for an accurate assessment of the bony architecture. Based on the preoperative radiographs, an appropriate level of resection of the anterior acromion is determined using the 5.5 mm burr as a guide. An orientation trough along the lateral acromion is gently tapered posteriorly to the level of the posterior AC joint. Now viewing from the lateral portal, soft tissue is again debrided using electrocautery, exposing the undersurface of the acromion, the bursal surface of the cuff, and the AC joint. By taking advantage of the watershed zones between the various arteries supplying these regions, we are able to perform this debridement in a bloodless manner. Beginning at the level of the posterior AC joint, we complete the resection, progressing medial to lateral and posterior to anterior, always resecting to the level of the lateral trough. This trough not only resects the prominent edge of the laterally sloped acromion, but it also serves as a frame of reference, preventing over-resection. The inferior osteophyte at the distal clavicle was then resected flush with a subacromial resection, preserving much of the AC joint itself. With our decompression completed, we now turn our attention to the rotator cuff. After debriding the degenerative and frayed edges of the cuff back to healthy and more robust tissue, we decorticate the footprint on the greater tuberosity to prepare an appropriate healing environment. We feel this is an important but insufficient step when performed alone, and we will therefore add bone marrow vents later in the case. Using a grasper, we then evaluate the tear morphology and tension when reduced to the native footprint. We elect to perform a 2-anchor repair using both simple and horizontal mattress suture configurations to address the L-shaped component of the tear and link both anchors together. Using a spinal needle, we identify an appropriate location and trajectory for our anchors prior to making a stab incision. Once we are satisfied, we proceed with placement of our posterior anchor. We prepare our pilot hole using a punch and follow this with a tap. We then place our 4.5mm triple-loaded peak anchor, taking care to orient the driver handle such that the eyelet of the anchor will allow each suture to run in a medial-lateral orientation. The driver handle is removed and the anchor is felt to be secure after pulling on the sutures. The repair begins by retrieving the medial limb of the most posterior suture at the anterior cannula. Using a crescent-shaped suture shuttling device via the posterior cannula, the intact infraspinatus tendon is pierced 1 centimeter posterior to the anterior edge, and a PDS suture is passed through the device. This is retrieved using an arthroscopic grasper at the anterior cannula, where the PDS suture is used to shuttle the retrieved posterior suture limb back through the rotator cuff and out the posterior cannula. The partner limb of the posterior suture is then retrieved at the anterior cannula. Grasping the posterolateral corner of the supraspinatus tendon, the degree of tension is again assessed with reduction of the tendon down to the lateral tuberosity. After the prior necessary debridement of the degenerative cuff edges and the preparation of the tuberosity, reduction of the tendon down to the far lateral footprint would be non-anatomic and result in excessive tension. So the tendon edge is held in a slightly medialized position on the footprint while a suture shuttling device pierces the tendon in an appropriate position. A PDS suture is used to shuttle the partner suture limb out the posterior cannula, making a horizontal mattress configuration. Not shown is retrieval of the medial limb of the middle suture out the anterior cannula. Here we see the suture shuttling device pierce the cuff and send in another PDS, which is retrieved at the anterior cannula and used to shuttle the middle suture limb back through the cuff in a simple suture configuration. Not shown is the retrieval of the medial limb of the anterior suture at the posterior cannula. Here we see the suture shuttling device pierce the cuff from the anterior portal and send in the PDS suture, which is retrieved at the posterior cannula. The PDS is then used to shuttle the medial limb of the anterior suture back through the cuff and out the anterior cannula. It is of note that the partner limb remains outside the skin. At this point, all sutures from the posterior anchor have been passed, with the posterior suture passed in a horizontal mattress configuration, and both middle and anterior sutures passed in a simple configuration. The anterior anchor pilot hole is then made in the same fashion as before, using a punch and a tap. An identical 4.5mm triple-loaded peak anchor is then placed, again taking care to orient the eyelet of the anchor such that the sutures run in a medial-lateral direction. The driver handle is removed and the anchor is felt to be secure after pulling on the sutures. The medial limb of the most posterior suture from the anterior anchor is then retrieved at the posterior cannula. A suture shuttling device is seen passing a PDS suture, which is retrieved at the posterior cannula. It is of note that this shuttling device pierced the rotator cuff between and slightly lateral to the middle and anterior sutures from the posterior anchor. This position can be seen here as the PDS suture is retrieved, shuttling the posterior suture through the cuff and out the anterior cannula. The partner limb of the posterior suture is then retrieved at the posterior cannula. A crescent-shaped suture shuttling device is used to pierce the cuff anterior and slightly lateral to the anterior suture from the posterior anchor. A PDS suture is sent in, retrieved at the posterior cannula, and used to shuttle the suture back through and out the anterior cannula. This places the posterior suture in a horizontal mattress configuration. Not shown is the retrieval of the medial limb of the middle suture out the posterior cannula. A shuttling device passes another PDS, which is used to shuttle the middle suture back through and out the anterior cannula in a simple suture configuration. Not shown is the retrieval of the medial limb of the anterior suture out the posterior cannula. The shuttling device and PDS suture are again used to shuttle the anterior suture back through the cuff and out the anterior cannula. With all sutures passed, we can see the anterior and middle sutures from the anterior anchor are passed in a simple fashion, whereas the posterior suture from the anterior anchor is passed as a horizontal mattress, with one limb posterior and one limb anterior to the most anterior suture from the posterior anchor. This results in a modified Mason-Allen stitch linking the two anchors together, as well as a ripstop stitch. We begin tying our knots from anterior to posterior. Using the suture passed through the cuff as our post, we tie a sliding locking SMC knot and reduce the cuff to the bone by repeatedly pulling the slack from the knot and retightening with our knot pusher. Once we are satisfied, the knot is locked while maintaining firm tension between the knot pusher and the post. Then, without reducing tension, we pass point with our knot pusher to further secure the knot. We then back up each knot with 3 half hitches on alternating posts. Both limbs from the middle suture are then retrieved at the anterior cannula and tied in the same fashion. Both limbs of the horizontal mattress posterior suture from the anterior anchor are retrieved and tied. Care is taken to place the knot posteriorly, such that when the anterior suture from the posterior anchor is tied over top of this, that knot will be anterior to this one, providing further suture interference. Both limbs of the anterior suture from the posterior anchor are then retrieved out the anterior cannula, and the knot is placed and secured anterior to the previous knot. This completes the modified Mason-Allen suture configuration, linking the two anchors together. The middle suture from the posterior anchor, which had been passed as a simple suture, was then tied. This was followed by the most posterior suture, which had been passed as a horizontal mattress. With all sutures tied, bone marrow vents are then placed in the greater tuberosity, allowing for the egress of marrow elements, including mesenchymal stem cells, growth factors, and platelets. Here we see a final view of our subacromial decompression, now with plenty of space between the undersurface of the acromion and the rotator cuff. We also see our fixation construct reducing the rotator cuff back to the tuberosity with excellent fixation. As the arm is internally and externally rotated, we note that the rotator cuff and humeral head move well as a unit. We can again appreciate our suture configuration while viewing from the lateral portal, noting well-tied knots with excellent loop and knot security. We see the posterior L-shaped component of the tear well reduced with the side-to-side horizontal mattress suture, and the remainder of the tear firmly secured under an appropriate level of tension using a combination of simple and horizontal mattress sutures, including a modified Mason-Allen stitch. As we turn down our pump and open the drain, we can observe the marrow elements egress from the bone marrow vents, producing the so-called crimson duvet. This concludes our case of the month. As always, we appreciate any questions or comments that you may have. Thank you.